Hey there, CyberMDs, and welcome to another cardiology lecture for the USMLE Step 2 exam. In today's lecture, we're going to be covering dyslipidemias. As always, please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources for students all around the world. Let's dive in. In broad strokes, today's lecture is going to cover an overview of dyslipidemias as a whole, as well as a little bit of a background. We'll talk about statins and when to use them and what to look for when you do use them. And in addition to that, we'll kind of finish up talking about alternatives to statins, as well as some long-term complications of untreated dyslipidemias. All right, so first, let's cover a quick background on lipoproteins. So lipoproteins are complex particles composed of various lipid molecules as well as proteins. Let's break down the primary components, which are cholesterol, triglycerides, phospholipids, and apolipoproteins. The most important thing to gather from this slide is that the varying ratios of these components is what primarily constitutes the difference between chylomicrons, VLDLs, IDLs, and HDLs. While cholesterol is a component of all of these lipoproteins, we commonly refer to all of these various lipoproteins as cholesterol. So remember that when we're talking to patients and even amongst ourselves, this is going to be what we're talking about when we say cholesterol is typically lipoproteins. Therefore, you may hear the term cholesterol used interchangeably with lipoproteins later on in this lecture. So let's talk about each one of these components one at a time. So triglycerides are going to be the fats that are derived from your diet, and they're also going to be your body's primary form of energy storage. So high levels of triglycerides can increase the risk of coronary artery disease and other atherosclerotic processes. Next is cholesterol, which is going to be this waxy fat-like substance, and that's going to be essential for building cell membranes, maintaining their stability and fluidity, and also synthesizing hormones. However, in excess, it also contributes to those atherosclerotic processes. Next is phospholipids, which are the predominant lipid that make up the membrane, the phospholipid bilayer, that membrane of lipoproteins, which is going to be their main function. And then last, we have the apolipoproteins, which are the protein components of lipoproteins. They serve as structural components. They help in the stabilization of the lipoproteins, and they are involved in the metabolism and the clearance of LDLs, IDLs, and HDLs. And so each of these becomes smaller and smaller, with chylomicrons being the largest and HDLs being the smallest, as you remove some of those fats and those triglycerides and that cholesterol, and that ratio of protein to lipids increases as that molecule becomes denser. Therefore, high-density lipoproteins are more dense than low-density lipoproteins, which are more dense than chylomicrons. And lastly, remember that dysfunction of these various apolipoproteins may be the cause of some inherited dyslipidemias. Okay, so let's break down the key characteristics of dyslipidemias. It's not necessary to remember all of these verbatim, but you should certainly be able to recognize when things are out of whack in your patient's lab results. So a dyslipidemia can be characterized as any of the following. The patient may have a low HDL. So HDL, or that high-density lipoprotein, is typically going to be what we call our good cholesterol. And remember that it helps remove other forms of cholesterol from your bloodstream. So low levels of HDL increase the risk of heart disease and can characterize a dyslipidemia. You also have high total cholesterol. So total cholesterol being the sum of all the cholesterol content in your blood. High levels can lead to, again, atherosclerotic processes. Your goal is for your patient to have a total cholesterol level less than 200 milligrams per deciliter. Borderline is, 200 to 220 or 240, and then high is most certainly over 240. That would definitely be a high total cholesterol level. And then any high non-HDL, so any high triglycerides or any high LDL, those can also characterize a dyslipidemia. So those are often the two most referred to, is going to be your triglycerides and your LDL as being high non-HDLs that characterize a dyslipidemia. Before we move on to the, so to speak, the meat and potatoes of the lecture, I kind of wanted to give you a few uncommon dyslipidemias that are still fair game on your exams. So you have familiar hypertriglyceridemia, and so this condition is characterized by elevated triglyceride levels in the blood, often without any significant increases in cholesterol levels, other cholesterol levels. And it's typically caused by genetic defects, and that's going to affect the body's ability to break down triglycerides. So patients with this condition are at an increased risk of pancreatitis, especially when those triglyceride levels are in excess of 1,000 milligrams per deciliter. And then management is going to focus on dietary modifications, weight loss, medication to lower the triglyceride levels. Next, we have familial hypercholesterolemia. So this is a genetic disorder characterized by high levels of low-density lipoprotein, or LDL, and that's going to be due to a mutation in the LDL receptor gene. This leads to impaired clearance of LDL from the bloodstream, resulting in accumulation and, again, increased risk of atherosclerotic processes, particularly cardiovascular disease. Management is, again, going to include lifestyle changes, some pharmacotherapy, typically statins, and those are all going to be aimed at reducing LDL levels in the blood. Moving on to familial chylomicronemia syndrome. This is a very rare genetic disorder and is going to be caused by mutations affecting lipoprotein lipase, which is an enzyme crucial for breaking down chylomicrons. Patients present with extremely high triglyceride levels and often have symptoms like pancreatitis. These patients may have the eruptive xanthomas that you've seen before in studying for step 1. They may have lipemia retinalis, which is an ocular finding. And management is challenging for these patients, but again, focusing on strict dietary fat restriction and triglyceride lowering medications. Lastly, let's talk about some various apolipoprotein dysfunctions. Mutations in the genes encoding the apolipoproteins can lead to various dyslipidemias, and that's kind of the general gist of the various apolipoprotein dysfunctions. But for an example, the ApoE mutations are associated with hyperlipidemias as well as other disease processes such as Alzheimer's. The management of these conditions is tailored to the specific dysfunction, and it's often going to involve, again, you guessed it, a combination of dietary management, lifestyle changes, and pharmacotherapy. All right, now let's discuss cholesterol management. Cholesterol management is a critical component in reducing the risk of atherosclerotic cardiovascular disease in our patients. Elevated levels of LDLs and triglycerides are huge risk factors for the development of heart disease as well as stroke. So our primary goal in cholesterol management is to lower these LDL levels and triglyceride levels, thereby reducing the risk of cardiovascular disease and stroke. Of particular importance in treating these conditions is going to be our high-intensity statins. So statins are the cornerstone of lipid-lowering therapy. They work by inhibiting the enzyme HMG-CoA reductase, which plays a central role in the production of cholesterol within the liver. High-intensity statins in particular are recommended for patients at high risk for cardiovascular events. These medications are proven to significantly reduce the LDL levels. The term high intensity simply refers to the dosage and the expected percent reduction in LDL levels. Some high-intensity statins have been shown to lower LDL levels by approximately 50% and even more in some patients. And then lastly, as mentioned, statins do aid in the reduction of these cardiovascular and atherosclerotic processes, so myocardial infarction, cerebrovascular accident or stroke, carotid stenosis, and ultimately, from those things, death. So you're going to see a significant reduction in all-cause mortality in these patients who need statins, who are provided statins. And this makes them a very invaluable tool in our arsenal against cardiovascular diseases and atherosclerotic processes. Now, Let's dive into one of the most important things, which is when to screen for dyslipidemia. So the practice of screening for dyslipidemia can vary significantly based on different guidelines, patient factors, as well as practice patterns of individual physicians. However, one of the key recommendations comes from the U.S. Preventative Services Task Force. Their current guidelines regarding statin therapy states that, and I quote, physicians should prescribe a statin for the primary prevention of cardiovascular disease for adults aged 40 to 75 years who have one or more cardiovascular disease risk factors. Those are going to include dyslipidemia, diabetes, hypertension, or smoking, and an estimated 10-year risk of cardiovascular disease event of 10% or greater. What I just stated was their most recent guideline as of the making of this video. Always make sure you check out the latest USPSTF guidelines after watching these videos, especially when you are on your family medicine and your internal medicine rotations. In my experience, I've seen many attendings screen patients much younger than this, even into childhood if their BMI is excessive or they have other risk factors. A lot of times this has been in accordance with old guidelines, but remember those are guidelines and real-world practice patterns will vary. Remember that. Real-world practice patterns will vary. So don't be confused if you study this for your test and then you go into a clinical rotation and you see a physician practicing something a little different. Again, you should know the USPSTF guidelines for your test, but be aware that you will likely see a lot of variability, again, in those clinical settings. When to treat the dyslipidemia is the next step. So we've talked about screening. Now let's talk about when do we treat. So the decision to start treatment is primarily based on that 10-year risk of atherosclerotic disease process that I talked about. And that's typically just going to be calculated using an online calculator. And you shouldn't memorize all the possible calculations and combinations and scenarios and their associated risk percentages. However, there are a few scenarios in which treatment with a high-intensity statin is automatically indicated, and those are worth knowing. So treatment is recommended in the following scenarios. If a patient has an LDL cholesterol level greater than 190 milligrams per deciliter, that's number one. Number two is going to be patients who have any presence of vascular disease, including myocardial infarction, stroke, transient ischemic attack, or mini stroke is what that sometimes may be referred to. If they have known peripheral artery disease or carotid stenosis, those would all be indications for statin. That's number two. Number three is if a patient has an LDL level between 70 and 190 milligrams per deciliter in patients with diabetes who are aged 40 to 75. So LDL between 70 and 190, age 40 to 75, and has diabetes. Those three things put together indicates a statin. And then number four is going to be LDL levels between 70 and 190, age 40 to 75, and then a 10-year risk greater than 7.5%. But again, you won't really be able to calculate that. I like to think that if they have more than three risk factors, it's probably over 7.5%. And so 70 to 190, 40 to 75 for age, and then greater than three risk factors, they probably need a statin. And so, again, just rolling through those risk factors one last time, making sure we don't forget those things. Smoking, diabetes, dyslipidemia, hypertension, age greater than 55 for women or 45 for men, as well as African American race. And when I say dyslipidemia, I'm referring to like a known familial dyslipidemia, one of those rare genetic disorders. Okay, so we talked about screening, we screened our patient, we talked about treating, we've decided to treat our patient, and now that we've decided to treat, let's talk about the medications and the dosing. So high-dose statin therapy, let's start with that. This is typically going to be reserved for patients with a high risk of cardiovascular events or those who have already experienced such events, which is what we were just discussing. So in that category for high-dose statins, we have atorvastatin, dosed at 40 to 80 milligrams per day, and then we have rosuvastatin, available in 20 to 40 milligrams per day. And those are the go-to options for high-dose statins. And I just remember atorvastatin 40 to 80. That's my start point for high-dose statins, and I'm just alternating to rosuvastatin and halving the dose. So 40 to 80, half of that's going to be 20 to 40. And then you move on to moderate dose statin therapy, and I have this laundry list on the screen. But what I just remember is, again, I said atorvastatin first, 40 to 80. That's what I memorized. And then rosuvastatin, 20 to 40. And those are my 2 high dose, right? And now for moderate dose, I go back to atorvastatin and I half it again. Half of 20 to 40 is 10 to 20. And then my next moderate dose statin option is rosuvastatin, and it's half of what was previously stated. So half of 10 to 20 is 5 to 10. And that's how I kind of remember my high dose and my moderate dose first line statins. If you need a low dose statin, it was always easiest for me to just remember lovastatin 20, and I didn't really bother ever remembering pravastatin and simvastatin. That was just how I approached it, because lovastatin for low dose statins was easy for me to remember. And so that's my approach to remembering these things. Obviously, I don't think a test is going to ask you to have this table memorized, but I think those 5 dosings are worth memorizing. So atorvastatin 40 to 80, then alternate and half the dose down to rosuvastatin for your other high dose. Again, moderate dose, atorvastatin 10 to 20, then half that for rosuvastatin for your other moderate dose, and then lovastatin 20 for low dose. And that's my approach to remembering what dosing and what drugs to give first line for these patients in which a statin is indicated. Now, let's discuss the aspects of monitoring and evaluating therapy. And that's going to be essential to ensure both efficacy and safety in the management of dyslipidemia in your patients. So first, routine lipid profiles are going to be a cornerstone in monitoring dyslipidemia therapy. So that's going to include measuring your total cholesterol, LDL, HDL, and triglycerides. And so regular monitoring is going to help in assessing response to therapy and then making the necessary adjustments to the dosing. Additionally, A1C levels are also typically monitored, especially in those patients who are diabetics, and there's going to be a significant interplay between glycemic control and lipid metabolism, so it's worth checking out your patient's A1C. Next is CK and LFTs, and that's going to be in the case of myositis. These aren't going to be routinely monitored for all patients who are on lipid-lowering therapy. However, if a patient begins complaining of signs of myositis, particularly if they're on statins, elevated CK levels can indicate that muscle damage, and abnormal liver enzymes may signal hepatic involvement. Therefore, you should possibly think about obtaining a baseline level prior to initiating therapy. I would venture to argue that that would be a smart thing to do. So next is going to be lifestyle modifications. Of course, we're going to want to preach about dietary changes, regular physical activity, smoking cessation, weight management, all of these modifications that can significantly impact our patients' lipid levels with less risk, potentially, than giving them a statin. So always talk to your patients about lifestyle modifications if you find that they have dyslipidemia and need statins. Next is going to be medication adherence. We want to make sure that our patients have the ability to get somewhere that can give them their medications, that they can afford their medications. So think about addressing barriers to medication adherence when prescribing statins and any other therapy, really. And then lastly, again, is statin toxicity. We talked about those elevated CK levels, those myositis. So again, look out for muscle aches, look out for weakness, unusual fatigue. Any of that can be causing that myopathy, that myositis. So regular patient education about those things is also going to be very important to make sure that your patient knows what they are looking out for in their own body. There are a few special cases for patients needing statins. So first, let's discuss patients with liver disease. As you know, statins are metabolized in the liver, and thus their use in patients with liver disease requires some consideration. The primary concern here is the potential for statin-induced hepatotoxicity, which, although rare, can be significant in these patients. So assess liver function, especially if your patient has liver disease, before starting a statin. And then when you're thinking about statin selection and dosing in patients with mild to moderate liver disease, they can still be used, just be cautious. The choice of statin and its dosage should be considered, so maybe think about a moderate intensity and then slowly titrating up to a high intensity dose. That would be worth thinking about in a patient who has liver disease who you think needs a statin. And then for severe liver disease, particularly in cases of decompensated cirrhosis, statins are generally going to be contraindicated. And make sure you're doing regular monitoring of your LFTs in patients with liver disease who you decide to put on a statin. The next consideration is going to be patients who have renal disease. So let's turn our attention to renal disease. The kidneys are going to play a role in excreting the statin metabolites, and thus renal impairment can affect statin excretion and increase the risk of adverse effects. So similar to liver disease, an assessment of renal function is essential before starting statins in patients with renal disease. This is going to include checking the serum creatinine and calculating an estimated GFR. And then in patients with mild to moderate renal impairment, most statins can be used safely, but again, careful selection, dosing, titrating up slowly, those are going to be key in these patients. And then the American College of Cardiology actually states that if a patient is already on a statin and then begins dialysis, there is no recommendation to stop the statin. Therefore, you will probably see some variability in practice on starting and or stopping patients who have end-stage renal disease and are on dialysis. You'll see some variability on prescribing statins to those patients. And then the last thing for renal disease, again, monitoring, making sure your patient is aware of what the signs of myopathy are so that they can be aware of what's going on in their body and know what the signs and symptoms are to look out for so that they can come in for prompt evaluation and treatment should those issues arise. Okay, when statins are not an option or when statins are not enough, we have some alternatives to lipid lowering medications at our disposal. So we have other lipid lowering agents. So let's go through them. They're listed on this slide, but there's a table on the next slide. So let's go through those one by one. I've listed the complications of chronic untreated dyslipidemia on this slide. I just wanted it here for completeness sake. I know most of these have been stated at some point during this particular lecture, but again, for completeness sake, I wanted this here. So thank you so much for tuning in. Please, again, remember to like, comment, and or subscribe so that we can continue to provide free medical education resources for students everywhere. Additionally, please feel free to leave us any feedback so that we can continue to improve these lectures and resources and continue to contribute to the free medical education community.